Welcome to Breaking Stereotypes. I'm your host, Kristy Ramnarine. We continue our discussion about perimenopause and menopause. Joining me on set is Kerry Montano and Dr. Shane Stone, and they're with the LYF clinic, and it's a hormonal clinic right here in Trinidad and Tobago. Kerry, I'm going to start with you because, you know, this clinic is now a thing because of you.
Yes.
You want to tell me, you know, about your personal journey and how it led into the formation of this clinic?
Sure. So a few years ago, I guess I was entering perimenopause, what we now know to be perimenopause, or what I now know to be perimenopause, because I didn't really know what was going on. I had a few symptoms showing up that weren't there before. There were a few sleep issues, just minor at first, some aches and pains, a little more fatigue, a little more brain fog, a little weight gain, just things that I just knew I felt a little bit off about. And I'm an athlete, so I do a lot of exercise and I burn a lot of calories, so I knew something was wrong, the way that I was feeling. I went to my primary care physician down here. I said, look, I'm just not feeling so great. There were some tests done. None were hormonal, but at the time, I didn't really put two and two together. And I was just told that everything was fine. I didn't really want to accept that because I knew my own body. And I was fortunate enough to be able to travel to the United States to go to a clinic up there. They tested my hormones, and that is when I realized that, you know, things were starting to change a little bit. I'm not in menopause yet, but I caught it early enough in perimenopause where I was able to get my hormones back on track. They did a little tweaking, and I felt amazing. The problem was I would have to travel up to the US every 3 to 4 months. It's very expensive. It's not sustainable. And, you know, I just realized this is really unfortunate because there must be so many women in Trinidad feeling the way I do and much worse, because I was just in the very beginning of it. So Dr. Stone and I have actually been really good friends since we were about 10 years old, and we've always kept in touch. I've always kept up to date on what he's been doing in Texas, and he mentioned to me that he would like to possibly move back to Trinidad, not with any intention to work. He still has his practices in Texas. I kind of twisted his arm and I said, look, I know you've been doing hormone replacement in Texas. There's nothing here. There's nothing. We need this. Some people are fortunate enough to travel, not sustainable. Most, there's just nothing here. And he agreed. He said, yes, I would love to come home and help you with this. We just wanted to help the woman here. It wasn't really anything more than that. And so we opened Life Medical 3 years ago, and it has been amazing. It's been so rewarding to see the changes that some of our female patients and males, but we're focusing on females today, have been able to see. And, you know, when they come back and say, man, I just feel amazing, it is so rewarding.
Yeah. Dr. Stone, you know, you specialize in hormonal optimization. You want to explain what that is to me?
Sure. So I can give a slight difference with, you know, when I'm in my practices in Texas, I still do full family practice. As Kerry mentioned that, you know, coming home here, I was a little confused as to how there weren't clinics that more specialize in this, or the people that just weren't comfortable with it. As I did a little more research, I realized that, yeah, we do have some very, very good OBs here, and sometimes their hands were just tied because of the access to certain things. Because I'm licensed in the States, it's easy for me to write prescriptions in the US for people to pick up or collect or have friends bring down, et cetera, that are safer, more bioidentical, and give people the opportunity to really get on good HRT. So I love the word optimization, because if you think about some of the ranges that are given for hormones, they're massive. So you look at TSH, which is a thyroid hormone, or thyroid lab, and the range goes from 0.4 to 4.5. Well, that's massive. Some people do great on the lower end, some people do great on the higher end, and you can tweak some of these things, especially when it comes to perimenopause and menopause, where you look at the labs, but you're also very focused on, well, you tell me how you feel. Tell me about your symptoms. And as we discussed just a little bit earlier, that the symptoms for perimenopause are probably in the hundreds. And it's the constellation of those symptoms and the clinical acumen to say, well, wait a minute, this joint pain that you just started having, this worsening anxiety, the brain fog, I can't sleep that well. You know, one of my favorite things a patient said to me is, Doc, 15 pounds showed up with a suitcase and refused to leave. And I love it because it's such an honest description of, I don't know what to do, I'm frustrated. And look, we live in a very, what's the right word? Very vain society, right? Which is great. It means people want to exercise, they want to be outside.
Good.
Exactly. But that really takes a toll on their mental health as well because they feel, look, I'm in my early 40s or I'm 50, I'm killing myself at the gym, I'm barely eating anything, which is not the right way to eat, but this is just the way that we treat these things when we're trying to self-medicate. And I'm so frustrated. And so this constellation of symptoms to me are things that you don't want to go see a specialist for knee pain. Sure, it may be an actual knee pain, but it also could be something that is underlying with many other symptoms that will give you a different way to go about treating them. And so that's where we come in, and a lot of other people can come in as far as just, what am I looking for in my patients? How do I give them a safe place to talk about these things? And unfortunately, I've done a lot of talks with large groups of women, some corporate, some more private, and their biggest complaint is I don't feel heard. I feel that when I talk about these things, there is a general consensus, whether it's in the medical community or whether it's in the pharmacy community or whether it's just with friends and family, well, I didn't go through this, so you should suck it up. Or, well, it's just menopause, you'll be fine. That's not the way that the standard of care is treated around the world. Like, women's health is now getting the funding that it deserves. In a lot of first world countries, this has been standard of care for a very, very long time. And, you know, we can talk in a lot more detail about the studies that have come out, the revamping of the analysis of different studies, the safety of these things. I can talk for hours on this stuff because it's so important, because the data is out there, and it's important that people are not still thinking of the rhetoric from 20 or 30 years ago. It's just not true anymore.
Can you tell me what's the big difference in your practice in Texas as opposed to Trinidad?
Yeah, so in Texas, I do everything, right? So I used to work in ICUs, nursing homes, I did everything. Coming home here, I still work in Texas, and so when Kerry pointed out to me that there was a gap in the market that I could help fill, and again, this is not a knock against our physicians. I think we have fantastic physicians in Trinidad. This is more of what I'm able to help patients do because of my access to things. Yeah. I just felt that I didn't want to open a full-scale practice here. I thought I would be too busy. I wouldn't have the time to focus on a gap in the market that I think I could help. You know, there's no intent on our part to steal anybody from their OB-GYN. In fact, you know, I think a lot of the patients would say, man, Dr. Stone and Kerry are encouraging me, make sure you get your mammograms, make sure you go back to your OB and get your ultrasounds and your PAPs, because this is a team. Yeah. There should be a team of people that are looking after a patient and that we're collaborating together simply for the benefit of the patient. So that, in a nutshell, is the difference. You know, I can, but I don't do a lot of the stuff I do in Texas here. There's just so many people that need help. I mean, we've continued to get busier and busier as the dialogue continues to improve. And just, you know, in true Caribbean style, it's a lot of word of mouth. As I mentioned to you earlier, somebody comes in and says, hey, I'm the guinea pig for my group of friends. And then they start getting good results or just have a good experience of feeling validated. And immediately we get a call from 5 or 6 of their friends. Hey, we want to come and have a chat about this. So I think a lot of it is the validation that people get of somebody's listening, somebody is not just telling me, go see these 3 different specialists to focus on one symptom, but what could be going on that's underlying all of these things?
You know, I'm going to come to you because you said the practice started 3 years ago.
Yes.
And Dr. Stone, you've been alluding to the fact that it's growing. Was it difficult to grow in the beginning?
No, not really. I think in the beginning, we put a couple Facebook ads out maybe, and then it just exponentially grew just by word of mouth. We don't run those anymore. But no, I think people are so want to get help that we haven't faced that at all. We've just grown.
For someone who would have gone to the U.S. to get this treatment, and now, you know, the clinic is offering it.
Right.
When you were going to the U.S., in my previous interview, one of the things which came up was the negativity surrounding HRT. When you went to the U.S., was this, you know, the case over there?
No, not at all. That is what opened my eyes to this whole HRT idea. It wasn't, as I said, it wasn't mentioned to me down here, but over there they were very, very proactive about it. And then they educated me about all of these things, and no negativity at all.
Yeah.
None.
And Dr. Stone, this is where I'm going to bring you back in. You know, again, HRT, one of the recent articles I just wrote, the fact that a study was done way back in 2000 or 2001, and that study was updated, you know, and there's no proof that women could actually get cancer from taking different drugs. What is the updated medical advice on hormonal therapy?
So, if you give me 2 minutes to discuss this tiny study, right? This was a massive study.
Yeah.
The end goal of that study was not to look at symptoms in women. It was, does HRT help prevent cardiovascular outcomes as women go through? The average age of the woman was over 60, which again, we're talking about perimenopause at 35, 40, 45. Yeah. When we think about HRT, if you have a uterus, you will always be given progesterone with estrogen. If you don't have a uterus, progesterone becomes more of, you know, is this person sleeping well? Do they need it for anxiety? But you can give somebody just estrogen. So this study was run where there was an estrogen only, estrogen plus progesterone, and then a placebo arm. And as they went through, of course, the end goal was, do we get better cardiovascular outcomes? And the answer is yes. What they also found was that in the estrogen plus progesterone arm, there was an increased risk of breast cancer. But here's the caveat. There's a difference between, this gets very, very technical, right? But there's a difference between what the absolute risk is and the relative risk. So the relative risk is what everybody talked about. Oh my gosh, there was an increase in 25% of, the actual risk went from 4 in 1,000 to 5 in 1,000. But that's minuscule.
Yeah.
And what was super interesting is that in the estrogen-only arm, the risk of breast cancer actually went down. The thinking was, well, this doesn't seem to be estrogen-driven. Perhaps it was a synthetic type of progesterone that was being used at that time, which we don't use anymore. Sometimes it's the only thing available in certain places, et cetera, but true bioidentical micronized progesterone is the standard of care. It's what should be used if you can get your hands on it. So, you know, I feel that when those numbers were re-looked at and they were like, well, wait a second, like this is not doing women a service. When we start looking at, well, what happens with osteoporosis? There's a decrease in osteoporosis and bone disease with women on HRT, decrease in dementia, decrease in cardiovascular disease, decrease in all-cause mortality, which is from all death. Mm-hmm. The data is clear. Does that mean that everybody's a candidate? Of course not. But there are also different forms of HRT. So for instance, if somebody has had a history of breast cancer, the thought is absolutely not, we can't give her it. That is not true. You can still get vaginal estrogen if you're having vaginal atrophy or GU symptoms such as frequent UTIs. And again, the safety data is available. The outcome data is available. This has been out for quite some time now. It is very difficult to break that stigma of any kind of hormone is going to cause cancer. So, you know, the important thing for me is when somebody comes in, I know this is a conversation we're going to have. I probably have it 15 times a day. And it's completely fine because it's an important conversation to have. But I take an incredibly thorough history about yourself, your family, who's your OB, what's your testing like, all of these types of things. And then we just figure out, okay, what test do we need to get? What are your symptoms? And then we look at what are you comfortable with? Because I could sit there all day and say, well, Kristy, I think you need X, Y, and Z. I think that your muscle mass is low. Testosterone is a massive player now in menopause as well. That was never thought of before, but it is across the world. You should get estrogen, you should get progesterone. And you can immediately panic and say, oh my gosh, that's too much. I don't think I want X, Y, and Z. And that's fine. I tell every one of my patients that HRT is an incredibly individualized personal thing because it's not just your lab. It's not where I look at your cholesterol and say, I don't really care how you feel, you need medication. This is a case where I do care how you feel. Are you comfortable with this? Here's what the data says. Here's what I think is going to improve. Let's try this for 3 months. And most of the time people come in and they're like, okay, I feel fantastic. What were you telling me about if I added this or if I added something else? Or can we switch the dose? And so sometimes we'll have a group of friends who come in, they all start off on the same stuff. And in 6 months, they're all on different formularies or on their different doses, all feel amazing. But it's just a testament to the fact that the way a patient feels really, really matters. And you know, it goes back to that first thing you learn in medical school about the detailed history. And to me, that perimenopause and postmenopausal history is incredibly important because it really guides, you know, what labs we're going to get, what we're looking at treating with, but also just a patient fare. what they're scared of, and what happened to their friend or their cousin or anybody. And you just have to take those stories into account, because I think if you try to downplay those, you're going to turn patients away from even wanting to have that conversation with you.
Mm-hmm.
Yeah.
Yeah.
Kerry, when you went to the US, what type of treatment did they put you on?
They started with some creams, which is sort of standard. You kind of start to go slow because you can absorb hormones through your skin. And then there's something called a pellet, which is implanted under your skin, which is kind of like the gold standard for HRT. It's definitely the most efficient most of the time, and that just releases a small hormone as you go along. But there are other forms as well. I didn't try those, but I know that they're available, and Dr. Sohn can tell you more about those. But, you know, they're patches, they're pills, they're vaginal inserts, they're vaginal creams. There's a plethora of different options you can use, but I just went the creams pellet route. I like to get to the heart of the matter. I don't like
And
to
after
go slow.
taking, what difference did you feel?
Oh, everything just went back to normal. I just went back to exactly how I felt before those changes started. Now, I was fortunate. I didn't have to, it wasn't very extensive, my treatment, because I caught it early, but it was very, very efficient. So, yeah.
And of course, my follow-up question would have been the different types of HRT available, and as opposed to what's available in Trinidad and the US.
Right.
So what I have seen that most patients get put on here, it's just what's available. Angelique, Progranova, et cetera, et cetera. You know, at first, to be very honest, I was very, very confused. It's not standard of care, and I'll go into a little more detail on that, but it just, I was very confused, and I started talking to some of the pharmacists, and then they clarified it for me. They were like, this is all we have. Now look, I'm not sitting here trying to come down on the pharmacy board. They have a million things that they're working on that they're trying to get. I'm sure that this is going to get solved, right? It is very easy for us to sit here and say, oh, people are dragging their feet and they should be doing X, Y, and Z. I'm sure there are a million things that they're working on.
Well, I'll give you a little history with one of my interviews before you go ahead.
Yeah.
When I had Dr. Kalu on, she actually made an appeal to the health minister, who was also an OB.
Right.
Perfect.
Yeah.
Yep. So I know it's going to happen, right? So I firmly believe that as this dialogue continues and more physicians and patients speak out about it, that it's just people are going to be more aware. So oral estrogen, the issue with oral estrogen is very simple. When you take oral estrogen and it gets processed in the liver, it increases clotting factors. So there's an increase in a possibility of blood clots. It's not a minuscule increase. It's the same thing when you're putting somebody on birth control at age 21. The questions you should ask are, you're a smoker, have you ever had a blood clot? Anybody, any family history of blood clots? Over the age of 35, as we get older, that risk just increases. Taking oral estrogen increases that risk. Any other type of estrogen, vaginal patches, creams, pellets, you bypass the liver, so you're not having, you have a minimal risk, but it's definitely not in that higher risk of oral estrogen. When it comes to progesterone, you know, we've had a couple different combination things in Trinidad. Again, some are oral, but they're the synthetic type. The best type of progesterone would be micronized progesterone, which is bioidentical. That's not, I shouldn't say it's not available here. I hear rumors of different pharmacies, they have a batch, and it's not consistently available here. That's when big changes will start happening, when we can all say, look, these things are available. And then, unlike, as Kerry mentioned, there are pellets. There are no pellets for progesterone, but there's estrogen and testosterone pellets. There's certain creams that can be compounded right here in Trinidad that patients try. Some people do very well on them. Other people say, look, I'm not comfortable putting on cream every day, or I just feel I sweat too much, or I don't want it to transfer to my pet, or a lot of these conversations. And again, this is where it goes back to, well, Kristy, what are you comfortable with?
Right.
And I could tell you what I think, but if you just say, there's no way I'm getting X, no problem, we'll start with these other things. You may come full circle and say, you know, I may have jumped the gun, tell me a little bit more about this if it's more effective. I'm just a big believer in that personalized approach with patients, because nobody's story is exactly the same. You know, nobody's pregnancy history is the same, nobody's family history is the same. And, you know, sometimes you read something and you get scared, and you should be able to speak to your physician about it. So a lot of my peers, even in the States, are just like, I hate when people Google stuff. I'm the opposite. I want you to Google it, just come ask me about it, so we can have an open conversation, right? I mean, people will come and tell me, well, I read this thing on Facebook. And I'm like, no problem, but now let's talk about it. Instead of just saying, well, that has to be correct, and whatever any of my doctors tell me is not correct. And I know that's very frustrating for physicians to have to kind of talk about things that, you know, okay, there's zero evidence that these things work. But I think it's important to have that conversation with your patients because they just trust you more. And they feel like, well, my doc gave me good reasons and showed me the study or showed me this. Why is this something that's probably not going to work? And why should something else be an option?
Yeah. And in terms of the patients in the clinic who have been, coming to you, what difference have you seen in terms of, or what feedback have you gotten from these patients?
I think we can both probably answer that, right?
Yeah.
So from my standpoint, it's the initial validation of just, you guys, you listen to me. And to both of us, because sometimes we'll speak to myself and to Kerry. And I think that, and you didn't tell me that this is just in my head, or you'll get past this, or just a host of things that there's no evidence that these things work, right? I'm all for trying certain things, but let's at least say, well, we know what the evidence standard of care is. And then when I see somebody come in and they tell me, my marriage is better, the way I treat my kids is better.
Yeah.
I don't want to quit my job anymore. I'm happy in my marriage. We're able to be intimate again. And I could go on and on and on. And Kerry hears this a lot as well.
Yeah.
You just feel happy for people because, and then you think, and then they would say to me, I think half of my job needs to come here because they're all unhappy. And it's so sad when you hear those stories, right? And, and again, I think that this situation is going to improve over time because I do think we have some very good physicians here. Some of the access they may have is just not what I have yet. And things will just continue to grow. I mean, there's no way. I mean, if we just look at our census in Trinidad of women from age 35 to 65, it's 100,000. What? I can't see 100,000 people, right? So this is something that's going to continue to grow, and the evidence and data is out there. And so you can speak about the things that you've heard from patients as well.
So, Kerry, before you do that, because time is going, that's fine. We had this conversation before we started the interview, and that's the stigma attached to perimenopause and menopause. And have you seen a difference in terms of that stigma, especially what we have in Trinidad and the Caribbean?
Honestly, I think, I don't want to say we started the ball rolling. Obviously, there were things before. But I think maybe I'm just more attuned to it now, and I have absolutely noticed a difference from when we started the clinic until now. Just, the attitudes of people, that taboo stigma is just kind of falling. And even I had it. I mean, even I didn't want to say, oh, well, I'm in my 40s, things are changing. But I totally understand it now because everybody goes through it. So I think the more that we speak about it, the more that it becomes the norm and the more that people are becoming very comfortable talking about it and sharing their experiences. And, just like things from the 1920s when we didn't do certain things, women didn't wear bikinis or choose anything from them. We're just progressing and becoming more up to date. So yeah, it's been a big change.
And of course, your patients also include men.
Yes.
Not just women.
Yes.
And what treatment do you offer the men?
So they mostly would be on testosterone. And again, they go through a screening process. I think I mentioned to you earlier, just like we do with the women, we go into a lot of detail with them, not just what is your range, but how do you feel. And just as an example, on a lab report, a normal range for testosterone would be 300 to 900. And if a patient comes in at 301, we're not going to say, well, you're normal and turn you away. No, it's very, very much how do you feel and what are your levels. And we stay very closely connected with all of our patients, male and female, constant check-ins. What do we tweak? How are you feeling? How are you doing? Lots of safety checks. So it's not just a one and done thing.
And Dr. Stone, how often do you come to Trinidad?
So I'm here most of the time now.
Yeah.
And it's flipped to where I spend most of my time now, and then I'm up in my clinic maybe 1 week a month. But and the other good thing is that we do a lot of virtual visits. We have some patients from Tobago, a lot of patients who are in the south or east part of Trinidad that we know traffic is not our friend.
Yeah.
And so, we try to have different hours where we have very early mornings or some afternoons. But virtual appointments are available, especially because there's so much to get from your patient with just hearing their story and their talking. And the other thing I think is, I want to throw this out there as well, Kristy, and this goes for both women and men. So in the US, there's a HIPAA Act that shows about patient privacy to the absolute max, right? One violation is a 10,000 US fine, etc. We practice the exact same way here.
Yes.
So the fear of a guy coming to see us, or even a woman who feels, well, I don't know if I really want my friend. I will walk past you straight in public unless you say hi to me.
Yeah.
I think that's the way it should be, because I don't know who you've told or who, and I just think that people should have absolute privacy, and especially because it's for both sexes, it's still a little bit taboo.
Yeah.
But either way, I think privacy is a very important thing for people to feel that they have in a small island, because everybody thinks, oh, well, if you went to this clinic, you must have X. Sometimes that's not true.
Right.
And if it is true, it's nobody's business, because
Right,
somebody's just trying to get better.
Yes. And then also, I just want to throw out there too, we think of hormones and we think of testosterone, estrogen, progesterone mainly. But hormones also involve, there are hundreds of hormones. Thyroid is one of them. So insulin. We look at all of these things. So it's not just, when we say HRT, the world sort of thinks those three, testosterone, progesterone, estrogen, but we actually incorporate everything. So we might have a patient that is having, say, sexual dysfunction, but it may not have to do with their testosterone. They may be diabetic, so then we'll deal with that.
Yeah. So,
yeah, it's not just the three.
And I like the fact that you brought that up, because obviously I was not thinking beyond.
Right, and most people don't.
Yeah.
Yeah.
So what's in store now? The clinic, it has grown.
Yes.
And, we've been talking about the fact that, more needs to be done locally in terms of the education when it comes to perimenopause and menopause, and the difference between, without knocking anyone, the difference between Trinidad and Tobago and the US. If you had a wish list, Dr. Stone, what would be at the top of it?
I think the top of it would be improving the safe space for women to speak about this. We know that we can always improve what we have access to. But, I think the data is out there. I think that for a physician, you have to know your patients are going to read this stuff. You want to make sure that you're very up to date with certain things. I think I owe it to my patients to be up to date in anything that I'm doing. And if I'm not, it's okay to say, I'm not really up to date with X, but Dr. Kristy is. You should go see her. I'm not a big fan of, of collaborations with people. I mean, I send people to specialists that I think are good specialists. End of story. I don't have to be partners with them or any of this stuff, right? Yeah. It's just, I think this person's a great surgeon. Kristy, you should see them. And I think that's how it should be. That we live in a small island. We're all fighting against the same beast of menopause, right? We talk about everybody has death and taxes. Well, women also have menopause. Yeah. It's a guarantee that you will stop having cycles. And so that has to become something that is discussed openly. And we start preparing people for it with no fear, with no shame. So I know that's a long wish list, but I think at first is that improving that safe space for people to discuss it without shaming them. And that goes both for women, but also men who want to talk about, I want to help my wife. I don't know how to broach this topic. Yeah. So that's a really interesting part.
Without getting cussed?
That's true. Yes. We have a lot of men that had no idea that the reason that their wife was more cranky or, I don't know, insert any symptom, was because of menopause. Yeah. So when Dr. Stone says relationships are different, there are marriages that have been saved. I mean, we see that all the time. And sometimes we have a husband and wife both come to us and they don't know that the other's coming to us. But because they're both on treatment, their relationship is just wow. Yeah. Sometimes there's a problem if a wife comes and a husband doesn't, and they both have hormonal issues and one gets better and the other doesn't. Then there can be a little, gap in, I don't know how good that is for the relationship, but when we have both that come, it's amazing. Yeah. But we are seeing more and more husbands actually getting involved in their wives' care. Husbands are attending visits, they're understanding more. And they're really, really empathetic now. And it's actually really amazing to see. I mean, sometimes a husband will come in just to say, thank you so much. My wife has improved and you've saved our relationship. And it's just really, really nice to hear. Yeah. Yeah. I'm sure it is, because one of my previous guests, her marriage broke up because of her experiences with menopause. Yes. Yeah. Yes. And it's just a lot of misunderstanding. And my wife is just a horrible person, but she's just really not. Oh, I think the most common one would be she's crazy. That. And I don't think it's only in marriage, but in the workplace or in the workplace. We have people going back to work that were not able to work before. So that's a huge thing. Because if you can't work, you're tired all the time, you feel depressed. It's just a downward spiral. Yeah. So I think what we're doing is great. we don't put band-aids on problems.
Yeah.
We're not going to put you on an antidepressant if you've come and say you feel depressed. We're going to get to the root cause of it and fix that. And that's really what we want to focus on.
Well, we've actually come to the end of the show, but I'm going to ask you, because I am certain when this interview airs, people will want to know how to get in contact with the clinic. So
Sure.
how can they do so?
So, okay, we have a website. It's lifemedicaltt.com. That's lyfmedicaltt.com. And on there, we have an online booking form. Our phone number is there. Our email is there. You can book an appointment through the website if you wish, or there is a number there that you can send a message to, and we can make your appointment for you.
Okay.
So it's all on the website. Our phone number is 868-393-8495. But that's also on the website.
Okay, great. Thank you so much, Kerry and
Thank you so
Dr.
much, Kristy.
Thank
Stone,
you for
for
having us.
coming on Breaking Stereotypes and continuing this very important discussion on perimenopause, menopause, and of course, HRT.
Thank you so much.
You're
It was so
welcome.
lovely talking to you.
That's it for Breaking Stereotypes. I'm your host, Kristy Ramnarine.